Namaste. I thank Dr. Karna for the opportunity to connect with you today. I have no financial disclosures. My lecture objectives are to mine the P's of giant cell arteritis and enhance the Q's, that is IQ and quality improvement, in the management of giant cell arteritis. We will compare the differences in giant cell arteritis presentation in India versus North America, and discuss paradigm shifts regarding the spectrum of GCA, the problems with the American College of Rheumatology criteria, and the use of ultrasound. I briefly discuss pharmacologic advances applicable to GCA, emphasize the role of platelets in diagnosis, and show the utility of prediction models as an adjunct to neuro-ophthalmic diagnosis. Although GCA is uncommon in India, with only 72 reported cases as of 2015, I hope this talk will keep you awake because, number one, GCA is a preventable cause of vision loss, and I estimate large centers in India might see 2 cases per year. 2, GCA is a disease of immunosenescence. When we conquer COVID and India increases its life expectancy, your incidence of GCA may increase. 3. New drugs such as tocilizumab and the immune checkpoint chemotherapy agents are being increasingly utilized and affect GCA. Tocilizumab is an interleukin-6 inhibitor and steroid-sparing agent that helps decrease remissions of GCA. Interleukin-6 inhibitors also have potential application in non-infectious uveitis and retinal vascular disease. The immune checkpoint inhibitors used for targeted chemotherapy include nivolumab, pembrolizumab, and ipilimumab, and can cause a drug-induced vasculitis. To review, giant cell arteritis is the most common primary vasculitis in the elderly and can result in irreversible and occasionally bilateral blindness in addition to myocardial infarction, aortitis, stroke, or death. GCA is classified as a large vessel vasculitis that can affect medium and small size vessels, notably the optic nerve and retinal circulation. The pathology of GCA shows granulomatous inflammation in the arterial wall with activated macrophages that may be abnormally large and multinucleated, leading to the appellation of giant cells. Giant cells are helpful in the pathologic diagnosis of GCA, but not essential. The immunology of GCA is complex. Age-related deterioration in the arterial wall and the immune system, with a relative deficiency of programmed cell death ligand 1, causes the normally quiescent dendritic cells in the vessel wall to become activated. Macrophage activation and the release of pro-inflammatory cytokines drive T-cell polarization to T helper 17 and Th1 lineages. In particular, interleukin-6 increases the Th17 cells that cause the inflammatory symptoms associated with GCA. Th1 cell proliferation causes an increase in interferon gamma with further macrophage activation, damage of the arterial wall, and vascular occlusion. There is a wide spectrum to the presentation of giant cell arteritis, from occult to isolated polymyalgia rheumatica, to fever of unknown origin, to large vessel vasculitis. As neuro-ophthalmologists, we are most familiar with the cranial GCA variant, presenting with headaches, scalp tenderness, jaw claudication, vision loss, and occasionally diplopia. A pallid swollen disc, central retinal artery occlusion, or diplopia in an older patient are classic ophthalmic presentations for patients with cranial GCA. Less common presentations of GCA include corneal edema, posterior scleritis, or lacrimal gland swelling from anterior segment ischemia. Retinal vein occlusion, facial nerve palsy, and deafness may also be seen by ophthalmologists. Early and accurate identification of GCA may prevent the progression of vision loss, or at least vision loss in the contralateral eye. The diagnosis of GCA can be difficult in part due to its wide spectrum of presentation, which can overlap with cancer, infection, and other diseases. There is no specific serologic marker. Erythrocyte sedimentation rate, or ESR, C-reactive protein, or CRP, and platelets are not specific for giant cell and may be normal in 4 to 10% of patients. Due to the difficulty in diagnosis and the side effects of glucocorticoids, temporal artery biopsy is traditionally performed to confirm the clinical diagnosis, although ultrasound is gaining traction. As a reminder, if you strongly suspect GCA, the patient should be on 1 milligram per kilogram prednisone while awaiting test results. Higher intravenous doses are suggested in patients with vision loss. Obtain your temporal artery biopsy, ultrasound, or MRI within 1 to 2 weeks so that glucocorticoid treatment does not confound your testing. Note that the 1990 American College of Rheumatology criteria for GCA are classification criteria and were not intended for diagnosis. The ACR criteria misclassify many neuro-ophthalmic cases of GCA, in part because age and ESR are dichotomized at or below 50 with loss of much statistical power. It is difficult for humans to accurately weight multiple predictor variables to determine a risk score for giant cell arteritis, especially if the variables have risk characteristics that behave in a non-linear fashion. Numerous studies have shown that properly formulated classification algorithms can outperform clinical intuition. To improve the objective diagnosis of GCA and decrease the number of temporal artery biopsies, we formulated and investigated a prediction model for biopsy-proven GCA compliant with the Tripod Transparent Reporting Guidelines and published this in 2019. In addition to the ACR criteria, we employed gender, jaw claudication, vision loss, diplopia, C-reactive protein, and platelets as predictor variables. To improve statistical power, age and blood work variables were maintained as continuous. From 14 predominantly North American medical centers, we retrospectively analyzed the data of 1,833 patients who underwent consecutive temporal artery biopsy. Complete case analysis of all 10 predictors was required for logistic regression and neural network models, and our final patient tally was 1,201 with 300 biopsy-proven cases of GCA. On multivariable analysis, gender and diplopia were not statistically significant predictors for GCA, which was confirmed on missing data analysis. Age, platelet level, jaw claudication, and vision loss were the strongest predictors for giant cell. Platelets, like ESR and CRP, are an acute phase reactant. Numerous studies have shown that thrombocytosis is a predictor for giant cell arteritis. We found that the platelet level was a more reliable serological predictor for GCA than ESR or CRP, with an average level of 372,000 per microliter in our biopsy-positive group. As such, if platelets cannot be maintained as a continuous variable, we suggest that the upper limit of normal for platelets in patients suspected of GCA should be lowered to 370,000 per microliter. This is further supported by the fact that platelet count decreases with age. The receiver operating characteristic curve shows that our prediction model in purple handily outperforms the 1990 ACR criteria in red. Although prediction models are not infallible, our classification algorithm weights the risk contribution of the 10 predictor variables without the bias of human intuition, and is especially useful for the continuous variables shown by the yellow arrows, which behave in a non-linear fashion. Our prediction model is accompanied by a freely available online calculator, which outputs an objective pretest probability for GCA without the intuition bias of human estimates. Using published data from meta-analyses on the sensitivity and specificity of temporal artery biopsy, ultrasound, and MRI for GCA, the post-test probabilities can also be determined using a Bayesian analysis. I now contrast the results of our North American study with published reports of GCA from India. Sharma et al. Compiled a total of 72 cases of GCA from different regions in India, published over 26 years. This, in combination with a report from Warfields of only one patient with biopsy-proven GCA of Indian heritage, supports the rarity of GCA in the Indian subcontinent. Now, what are the possible reasons for this? Well, GCA is a disease of immunosenescence. The average life expectancy in India pre-COVID was 70.4 years, which is 11 to 13 years less than in North America and Scandinavia. Although this partly accounts for the decreased incidence of GCA in India, there must be additional genetic and environmental factors given the infrequency of GCA in Hong Kong and Japan, which have the highest longevity per country. Direct comparison of Sharma's report with our North American study shows that on average patients in India were 10 years younger, predominantly male, with 20% more headache symptoms and 30% more temporal artery abnormality, but 10% less jaw claudication in India. In both groups, the rate of vision loss associated with giant cell was 30%. Gender was not a statistically significant predictor for GCA on our multivariable analysis, and the 72% predominance of females in our North American series may be in part due to the increased survival of women versus men in Canada and the United States. In India, there is a 1.6 times male predominance of GCA, perhaps attributable to smoking. It is known that smoking increases the risk of giant cell, and one meta-analysis showed a statistically significant odds ratio of 1.18. Also, BDs have a more deleterious effect on health than cigarettes. There are at least 10-fold more male smokers than female smokers in India, which is a much higher male proportion than in North America or Scandinavia. Fluorescein angiography, orbital color Doppler, ocular pulse amplitude, and OCT angiography are studies that estimate ocular blood flow and are adjuncts in the diagnosis of cranial GCA. Imaging or biopsy the temporal artery is usually still required to confirm the diagnosis of GCA. In this last segment, I discussed the controversy of imaging versus biopsy of the temporal arteries. The main imaging modalities are ultrasound, MRI, and positron emission tomography scan. I have no experience with PET-CT, but a disadvantage of PET is that it cannot distinguish between the increased uptake of GCA patients versus polymyalgia rheumatica patients. 3 Tesla post-contrast fat-saturated multi-slice T1-weighted spin echo MRI of the temporal and scalp vessels perpendicular to the orientation of the vessels holds promise and has a sensitivity of 73% for giant cell arteritis. 20% of patients with giant cell may show some inflammation of the temporalis muscle. MR angiography, MRA, 3D time of flight technique through the scalp arteries and circle of Willis with head coils does not require gadolinium and can be used in patients with renal failure. MRI of the orbits may show enhancement of the optic nerve or chiasm, but is not specific for the diagnosis of GCA. I concentrate the remainder of my discussion on the debate between Doppler ultrasound of the temporal arteries versus temporal artery biopsy as the confirmatory test for GCA. Temporal artery biopsy is the traditional reference standard for the diagnosis of giant cell, but is an invasive procedure and may require several days for the pathology result. Rubenstein's 2019 meta-analysis suggests the sensitivity of temporal artery biopsy is 77%, which is likely due to skip lesions. The specificity of temporal artery biopsy is considered to be 100%, and pathology allows identification of alternative diagnoses such as amyloidosis. Temporal artery biopsy may cost more than ultrasound and has the potential but infrequent complications of facial nerve palsy and rarely scalp necrosis or stroke. Please note that when I refer to Doppler ultrasound of the temporal artery, it is not the same as orbital color Doppler, which qualitatively and quantitatively assesses retrobulbar blood flow. With Doppler ultrasound of the temporal artery, the main objective is to look for a thickened arterial wall due to edema, which appears as a non-compressible hypoechoic halo. Rheumatologists in the United Kingdom and Europe with expertise in ultrasound advocate ultrasound as a first-line investigation for giant cell arteritis in their rapid access clinics. A 15 to 18 megahertz linear ray transducer focused 5 mm below the skin is recommended. On meta-analysis, the sensitivity of ultrasound for GCA varies from 68 to 77%. Ultrasound can examine the entire superficial temporal artery, other scalp vessels, as well as the axillary artery. In general, ultrasound studies cost less than biopsy at centers that have paid for the capital outlay for ultrasound equipment and staff training. Serial ultrasound can determine the response to medication. However, there are at least 5% false positives. Atherosclerosis, amyloidosis, lymphoma, and infections can have false positive ultrasound halos and result in inappropriate glucocorticoid use and toxicity. Recently, the European and the British Rheumatology Society suggest that at centers with sufficient ultrasound experience, ultrasound can be the first-line test for GCA rather than biopsy. Schaefer's OMERAC study suggests that an experienced sonographer has performed more than 300 ultrasounds for GCA. I reemphasize that meta-analyses from the rheumatologic literature, using largely the same articles, show that ultrasound may or may not be as sensitive as properly performed temporal artery biopsy. Renegel's group contacted the authors of the ultrasound articles for missing information. The 5% false positive rate of ultrasound from disease processes including atherosclerosis may be exacerbated by confirmation bias if the same clinician examines the patient and then performs the ultrasound. In my opinion, the side effects of unnecessary prolonged glucocorticoids from false positive ultrasound halos exceeds the disadvantages of temporal artery biopsy. Individual clinicians must decide, given the gamut of steroid-responsive diseases that mimic giant cell, whether a 5% false positive ultrasound rate is acceptable. The TABUL study comparing ultrasound and temporal artery biopsy is frequently cited in support of ultrasound for GCA. Unfortunately, the TABUL abstract does not mention that the performance of temporal artery biopsies was substandard in comparison with their excellent ultrasounds. 7% of the TABUL temporal artery biopsy attempts did not even yield an artery. When arterial specimens were obtained, 43% of the cases were less than the 1 centimeter length suggested by the British Society of Rheumatology to avoid skip lesions. Please note, I'm not against the use of ultrasound or MRI and would be quite elated to never perform another temporal artery biopsy. Use the test modality that your center has available and is most expert at, realizing that not infrequently you may have to combine pathology and imaging. If you're planning to use ultrasound or MRI to diagnose GCA in the future, it would be prudent to correlate your first 50 imaging diagnosed giant cell cases with pathology. The use of prediction models should provide higher yields from testing and perhaps reduce the number of temporal artery biopsies performed on low-risk subjects. In summary, I hope I've been able to keep you awake and nail in the following points. Although GCA is uncommon in India, it is an eminently preventable cause of vision loss. Patients in India are predominantly male and most commonly present in their 60s, a decade younger than their North American counterparts. There is a wide spectrum to the symptoms and signs of GCA, which vary from occult to fever of unknown origin to large vessel vasculitis, and the more familiar cranial GCA. The 1990 American College of Rheumatology classification criteria are not meant for diagnosis and require updating. Temporal artery biopsy is the traditional reference standard for the confirmation of the clinical impression of GCA, but ultrasound is gaining traction, especially in Europe. However, both temporal artery biopsy and ultrasound require experienced practitioners to attain adequate performance parameters. Platelets are a stronger predictor of GCA than ESR or CRP. We lose statistical power when we dichotomize age and blood work variables. Concerning pharmacotherapy, tocilizumab, an interleukin-6 inhibitor, is a new steroid-sparing adjunct that decreases the recurrences of GCA. Although my North American GCA prediction model may not apply to India, I encourage you to develop and use prediction models for your more common neuro-ophthalmic diseases as an aid to objective risk stratification. Thank you much for this opportunity to speak. I wish you all invincibility in your work against neuro-ophthalmic diseases and COVID.